Hello, everyone. My name is Lindsay Foman. Today, I'm presenting my health policy analysis focused on improving access to palliative care services across hospitals and outpatient settings. This is a topic I work every single day, and the inconsistencies in access that I personally see across hospitals is exactly why I chose it. Some hospitals I serve only have access because my organization provides palliative care support at little to no cost, while others have no access at all. This presentation outlines how we can fix this at a national level. Here's what I'll walk through today. First, I'll explain what palliative care is and why it's so essential. Then I'll describe the scope of the problem, including the policy and financial barriers that prevent hospitals from offering these services. Next, I'll summarize current federal and state policy gaps and introduce three potential policy solutions. I'll share the recommended national policy and show how it can be implemented as well as evaluated. By the end, you'll understand why this issue matters and how an national approach can create equitable and sustainable access. Before addressing the policy, let's watch this short video.
Palliative care is a new medical specialty that's focused on maximizing quality of life for patients with serious illness and their families. It provides an added layer of support so that patients pursuing active medical treatment of their disease get help with things like symptoms, practical needs, support for families. We work with the patient's other physicians to make sure that the care is as high quality and the life is as high quality as possible.
One thing I have to address before we even get started is something so important and something so obviously misunderstood by many. Hospice and palliative care are not the same. I'm going to say it again. Hospice and palliative care are not the same. Palliative care is a specialized medical support for individuals living with a serious illness. It focuses on symptom relief, reducing emotional stress, and improving quality of life. The difference is that it can occur at any stage of illness and alongside any type of treatment. Unlike hospice, which supports the same overall areas of opportunities, however, those patients are meeting a prognosis of 6 months or less and most often not undergoing aggressive or curative treatment. Palliative care significantly improves outcomes for patients with advanced illness, such as cancer, COPD, heart failure, dementia, the list goes on. It reduces avoidable emergency room visits, improves symptom control, and helps families understand their options. When palliative care is involved early, transitions between care settings are smoother, communication improves, and families feel supported instead of overwhelmed. I see the difference in real time when hospitals collaborate closely with the palliative team. The core policy issue is that access to palliative care is inconsistent, especially across hospitals with fewer resources. Many patients never receive palliative support simply because their hospital doesn't offer it. I see hospitals hesitate to develop palliative programs because they don't generate direct revenue. Without reimbursement or formal payer agreements, systems rely on hospice providers like mine to try to fill these gaps, often at our own cost. While we do this because patients need the care, it is not always sustainable and creates inequities that require national policy interventions. This issue directly affects healthcare systems. Palliative care improves quality scores, reduces readmissions, and strengthens communications between teams. Yet, many hospitals will avoid developing these programs because of that unclear reimbursement, the staffing shortages, and concerns on the overall cost. Some systems avoid partnership agreements with hospice providers, even when those agreements could support transitions and reduce unnecessary utilization. This disconnect between known patient benefits and financial barriers is a major policy challenge. The main goal of this policy is to ensure that palliative care is accessible and reimbursed across both hospital as well as outpatient settings. To accomplish this, we need a national definition of palliative care, reimbursement structures, and support for building clinical teams. Ultimately, the goal is even access, regardless of where the patient lives or which hospital they visit. Across the country, access varies widely. Only 72% of hospitals with 50 or more beds offer palliative services. Outpatient access is even more limited because insurance plans often will not reimburse palliative visits unless the patient meets a certain criteria. Smaller and rural hospitals are especially likely to lack these services entirely. Patients with serious advanced illness may never receive coordinated symptom support unless the hospital has a partner organization willing to provide it free of charge. There are four main reasons access remains inconsistent. First is a financial strain. Palliative consults do not reliably reimburse, making them difficult to justify within hospital budgets. Second is confusion among clinicians between palliative and hospice care. This confusion delays referrals and makes teams hesitant to introduce palliative specialists early. Third is the workforce shortage. There are simply not enough trained palliative clinicians to meet the national demand. And fourth is the informal reliance on other teams to provide the support at no cost, which can mask the systematic issue. Several policies exist, but none guarantee access. The CMS SIP model focused on care coordination, but saw low participation. The VBID model allows Medicare plans to offer palliative benefits, but coverage varies widely by region. The Enhancing Oncology model requires goals of care conversations, but does not reimburse full palliative services or interventions. At the state level, 29 states have palliative care information laws, but these only require patient education. It does not coexist for staffing, funding, or even infrastructure. The gaps are clear. We lack standards for palliative access. There's no reliable reimbursement, a lack of workforce development programs, no outpatient coverage, and really no federal oversight and quality measures. Because of these gaps, access will remain inconsistent and fragmented. Every stakeholder is affected. Patients want symptom relief and clear guidance. Families want support before a crisis. Hospitals want improved outcomes but cannot fund non-revenue services. Payers want lower costs but have not created strong reimbursement pathways. And clinicians want better coordination, especially during hospital transitions. In my work, I see all of these perspectives play out across different hospitals every single week. So option one, the first option is voluntary adoption. Hospitals may choose to develop palliative programs and may receive small incentives. While this offers the flexibility, it lends to that uneven adoption, especially exactly similar to what is going on today. Patient and large hospital systems have that access, while as mentioned, rural or small hospitals will still have none. The hybrid model mandates certain components but allows others to remain optional. This approach provides some structure but still leads to a wide variation in access. And monitoring compliance across different states becomes quite complex. It improves the current system, but it does not fully address the issue. This model establishes national requirements for palliative care availability in hospital and outpatient settings. It expands reimbursement, supports telehealth, and funds workforce development through national grants. This is the only option that would ensure consistency and across the nation. Each policy option was evaluated using clear criteria: practicality, stakeholder support, effectiveness, access, sustainability, and feasibility of implementation. The mandatory national policy outperforms both alternatives across all criteria. Research shows that palliative care reduces unnecessary procedures, lowers hospital utilization, improves symptom control, and increases family satisfaction. Studies indicate roughly 20% reduction in total costs when palliative care is involved. From my own experience, when palliative teams support patients early, the outcomes improve and transitions become smoother and safer for everyone involved. Based on all the evidence and evaluation criteria, the recommended policy is the mandatory national model. It eliminates the financial barriers from hospitals, supports training programs, and expands reimbursement, and promotes equality through national standards. The implementation process. Let's talk through that, right? Phase 1 focuses on establishing national definitions and activating CMS reimbursement codes. This immediately removes the biggest obstacles facing hospitals, which is funding. It sets the foundation for consistent access across all health systems. Phase 2 begins the rollout. Larger hospital systems will adapt first, and then closely followed by rural or community hospitals with grant support. This phased approach will prevent smaller hospitals from being overwhelmed and ensures consistent training and onboarding. And lastly, phase 3 formalizes the partnerships with organizations that already have strong palliative expertise. This includes shared staffing models, regional palliative centers, and telehealth support. Many hospitals already rely on these partnerships informally. This policy brings structure and funding to those collaborations. Success will be measured by the number of hospitals offering palliative care, reduction in emergency visits and readmissions, improved symptom management, higher family satisfaction and quality metrics on a hospital perspective, reduction in Medicare spending. These measures ensure the policy is monitored, effective, and improving outcomes. Long-term sustainability requires ongoing workforce development, continued reimbursement, national oversight, and integration into CMS quality programs. This ensures palliative care remains a permanent, supportive part of the healthcare system, not a temporary initiative. In closing, expanding access to palliative care is one of the most meaningful ways we can improve care for people living with an advanced illness. I see the impact every single day when palliative teams are involved early. Patients experience better care and families experience more clarity and peace. But too often, access depends on a hospital's financials or whether a hospice provider is able to fill those gaps. A national policy ensures everybody has access to care, access to compassionate, coordinated palliative care for every patient in every setting across the country. Thank you so much for listening, and I look forward